I'd like to thank the organizers for giving me the opportunity to talk about one of my favorite topics regarding MDS. It's about erythropoiesis stimulating agents and other growth factors. These are my disclosures. We heard from Fabio in the previous session that quality of life is definitely impaired in MDS, and as Fabio showed, fatigue and dyspnea are two of the major symptoms that patients complain about. And although this depends on many factors, one of the major factors is the anemia that is tightly associated with MDS. And from cancer in general, we know that anemia is linearly correlated with global quality of life all the way up into the normal range. So if you have an MDS patient that is transfused at relatively low levels compared to a treated patient that is able to maintain an essentially normal hemoglobin, likely this patient does a lot better. I'd like to start with a case here. A 66-year-old patient with MDS with ring sideroblasts that had a typical picture of gradually, slowly declining hemoglobin over the course of 5 years. When it reached below 100, EPO was initiated at a high dose, 70,000 units per week for 12 weeks without any response. G-CSF was added for 12 weeks, and the hemoglobin was rapidly increasing up to normal levels. And this patient maintained a normal hemoglobin essentially for about 3 years and good hemoglobin for another 2 years and was able to work full time during this period. And in fact, the first transfusion was given as much as 8 years after the start of ESA treatment. And at that time, there was no sign of marrow progression. So we'll go through these things a little bit more in detail. And we'll just start off with a brief thing about the mechanisms of action, which I think is important to point out. Generally, you consider that EPO stimulates the erythroid cells, and perhaps you think mainly the normal remnant cells. But in fact, in MDS, we believe that EPO and G-CSF enhances the survival of the MDS sort of deficient erythroblasts. And we know that the erythroblasts do express the G-CSF receptor. And if you give the combination especially, you clearly can observe an increase of abnormal erythroid cells that have a high MCV level and are also hypochromic. You can detect those in the blood. And so that clearly indicates that it's the MDS clone that actually is able to propagate and generate more red cells. And in part, we believe that this is due to a reduction in mitochondrial cytochrome C release, which is one of the major factors contributing to the increased apoptosis, at least in MDS with ring sideroblasts. And in part, this may be thanks to a restoration of MFN2 levels that is important for the membrane stability in this disease. If we take a step back and just look at the evidence from randomized trials, there are 2 trials clearly demonstrating superiority over supportive care for EPO with or without the addition of G-CSF. There is also clear evidence of a synergistic effect of the combination treatment, and we know this from one randomized trial from Italy that demonstrated a clearly higher response rate, although it didn't quite reach significance due to the low patient number, most likely. In the Nordic countries, we have performed 3 studies where we also had clear synergistic effects with the treatment, with a lot of patients being rescued when adding G-CSF and so on. There's also data from the French group indicating that addition of G-CSF may rescue non-responders to EPO alone. As you know, there are multiple different versions of EPO analogs and also darbepoetin with a longer half-life. And in my view, all of these have relatively similar efficacy. And the response rate in phase 2 trials vary greatly, in fact. But I believe that's due to other reasons, such as patient characteristics and also response criteria. In a meta-analysis by Victor Moyo a couple of years ago, he identified a large number of patients treated evaluated with similar response criteria. And here, in fact, at least EPO and darbepoetin had very similar response rates. Another thing that is very evident is that as time goes by, the response rate increases, in fact, linearly, and likely this is due to patient selection. We know which patients to treat and which not to treat. So the inclusion criteria varies, and the patients are also on average treated earlier. We know, as you're aware, that the probability of response greatly is affected by the serum EPO level and the level of transfusion need, and this is the standard predictive model looking into this, and you can identify a good predictive group with about 74% response rate, intermediate 23%, and a poor predictive group that hardly ever responds, and if they do respond, it's just for a brief time, and this poor predictive group should not be treated with growth factors. The quality of the response differs depending on the depth of response, and the response characteristics is also greatly affected by the IPSS risk categories. And overall, the response duration is about 24 months, but if you split it up into complete and partial responders, where complete responders are the ones that reach an essentially normal hemoglobin above 115 grams per liter, then the response duration is 29 months in median, whereas if you reach a partial remission, it's about 12 months. If we compare the low versus the higher risk groups, the response rate is higher and also the duration. Overall, about 20% of responders responded longer than 5 years, which is a substantial amount of time, I'd say. And again, here, if we look at the curves for the complete versus the partial responders, we see that this greatly differs. And the complete responders, actually, a number of patients do maintain a good response for many years. There's been some attempts to further improve and refine this prognostic score, and one of the more interesting attempts, I believe, was from Teresa Westers and Arjen van der Lostrecht in Amsterdam that are experts at flow cytometry, and they looked at the influence of the aberrant phenotype of myeloid blasts in MDS, and it's clear that this adds predictive information. So they generated a relatively easy score based only on serum EPO level and the presence of aberrancies in the myeloid blasts. So if you have a low serum EPO below 100 and a normal blast profile, then you have about a 94% probability of response. More recent data from our own hospital at the Karolinska, we looked into the subset of MDS with ring sideroblasts, and we identified 39 patients that were anemic enough to require treatment with EPO. And here, about 3/4 were in the good predictive group, 1/4 was in the intermediate, and none was actually in the poor predictive group. 79% were non-transfused, and all the patients had a serum EPO level below 200. So this clearly indicates that we identified most of these patients at an earlier stage compared to the patients included in the earlier clinical trials. The response rate in this subset was 92%, where 54% had a complete erythroid response. And so likely, we believe that the patients are treated earlier, they had a lower serum EPO level and were less transfused, and of course, we only nowadays treat low-risk MDS. The high-risk MDS get other types of treatment. And we also saw a difference here in the response duration between the patients with unilineage dysplasia compared to the multilineage dysplasia, and this is also seen in several other trials. This is an interesting story, I think, from the EU-MDS registry, where Hege Garelius from Gothenburg in Sweden made an analysis of low-risk patients. Then it's 1,000 patients, and looking between different countries, the proportion of patients treated with ESAs varied between 20 and 60%. And the ESAs were started at different degrees of anemia in Portugal at about hemoglobin of 84 grams per liter, whereas in Sweden they are just borderline anemic at 102, which I think is an interesting observation. Regarding quality of life, we heard about this. There are a number of trials indicating a positive effect on quality of life. Regarding randomized trials, there was a tendency that they were actually improved in responders, but generally that's not the main endpoint, and as Fabio alluded to, I think we need to be better at designing studies to look for this. With regards to survival and risk of AML evolution, there are some studies that have tried to address this. We performed a study together with the Pavia group, with Mario Cazzola and Luca Malcovatti. We compared the patients treated within the Nordic MDS group trials with the Italian patients that were actually untreated, at least no growth factors. And we did here identify an indication of a survival benefit. And these curves are adjusted for multiple variables with all the standard prognostic measures. And on the other hand, we saw no effect on the AML evolution, which theoretically has been a concern, especially for chronic treatment with G-CSF in diseases such as MDS that does have an inherent risk of leukemic evolution. But we did not observe this in this study. A similar study was performed by the GFM group in France, Sophie Park, and they compared French treated patients with untreated patients from the IPSS database. And here, again, there was a clear trend that the EPO responders had a better overall survival, whereas the non-responders had an essentially equally poor survival as the non-treated patients. And again, this holds true also in multivariate analysis and match control analysis. So how do we use MDS? We'll just go through this very quickly for those of you who are a little bit not used to this. So the indication then, according to most major guidelines, is that you should have a low-risk MDS up to the intermediate 1 or intermediate according to the IPSSR, predicted group high or intermediate according to the predictive model. Usually we start at a dose of 30,000 units of EPO or 150 micrograms per week with darbepoetin for about 8 weeks. If no response, we double the dose and continue for another 8 weeks. If still no response, we add G-CSF for another 8 weeks, and we try to aim for a neutrophil count of between 6 and 10. That's usually the goal in the clinical studies. And the target hemoglobin is 120 grams per liter. Eventually, patients do lose their response, obviously, and on average, that's after about 2 years. And regarding marrow progression, that only occurs in about a fourth of the patients, and this is actually not that common. And of course, you should evaluate for iron deficiency or even functional iron deficiency and vitamin B deficiency. Pure red cell aplasia is not an issue, I'd say. We recently looked into the mutational profile of patients losing the response to treatment, thinking that even though we don't see any difference in the marrow morphology, maybe they have acquired novel mutations that makes them refractory to EPO. And we were not able to find a clear correlation here. 8 of these 12 patients had a completely stable mutational profile. 3 did gain an additional mutation, but 1 also lost the mutation. So I think for sure this is not clear-cut. So most often the reasons for loss of response is not any obvious marrow progression. If we move on to other erythropoiesis stimulating agents or growth factors, then we have romiplastim, that is a TPO agonist, as you're well aware of. There was a study published 2 years ago by agonists that looked at a large cohort of patients, 250 patients with platelets below 20 that were actually significantly thrombocytopenic. And there was a clear and relatively rapid platelet response, 36% at 4 weeks, about 60% at 8 weeks. There was no difference in significant bleedings, but there were less platelet transfusions required in the treatment group. And as you are aware of, Probably this study was stopped early due to safety concerns, since there was a higher proportion of patients in the romiplostim group that had an increase of peripheral blasts in the circulation, and it declined after stopping the drug. And however, there was no clear difference regarding the rate of AML evolution. But this was sort of scary, and currently, as far as I know, the development in this setting is stopped. The other TPO agonist, eltrombopag, is not published yet, but it was updated at ASH last year by Oliva. And here there were 70 patients with lower risk MDS and platelets below 30. The mean platelet count was 17, and almost half were platelet transfusion dependent, so these were severely thrombocytopenic. Here they were aiming for a high dose of eltrombopag, all the way up to 300 milligrams daily. The platelet response was 50% in the eltrombopag group, with a median increase of 53, which I think is a clear, meaningful response. And again, the median time to response was relatively short, only 14 days. And the median dose was 75, so most patients did not have to go up until up to the very high levels. Eltrombopag has also been explored in higher risk MDS, and Uwe Platzbecker has led this trial in relapsed or refractory AML or MDS with platelets below 30, and this was 98 patients. And again, the dose of eltrombopag was up to 300 milligrams daily. And the idea here was both perhaps to increase the platelets, but also to see whether there was any effect on the clone, since preclinical data indicated that eltrombopag in high doses might actually have an anti-leukemic effect. Unfortunately, there were no significant platelet responses. There were some hematological improvements. There was also a tendency towards fewer bleedings and fewer platelet transfusions in the treatment group. Importantly, though, there was no difference in peripheral blasts or the rate of AML evolution. On the contrary, in fact, there was a trend towards better overall survival. This is progression-free survival in the eltrombopag group compared to placebo. So this is interesting data, but of course, it would have been nice to see a better improvement of the platelets. What about combination treatments? One important thing that has been explored is to combine with the lenalidomide, and preclinical studies have indicated that there may be a synergy here, and there are 2 published studies, to my knowledge. One here that looked at lenalidomide in lower risk MDS transfusion-dependent ESA failures, and that were randomized them between lenalidomide or the combination. And here there was a trend towards a higher degree of transfusion independency in the combination arm, and there was a significantly improved hematological improvement with the combination. However, if we look at the response duration, it was not clearly improved. If anything, it was slightly inferior in the combination arm. Another study had another approach here in transfusion-dependent MDS, low-risk MDS. And if we look at the non-del(5q) samples, patients, and concentrate on the non-responders to lenalidomide, they did receive the combination treatment for 8 weeks. And here, 21% of the patients responded to the combination. So there is some evidence of a combination effect, but regarding the clinical implications and how to use this in common practice, it's too early to say. So we cannot recommend this at this stage. EPO has also been combined with azacitidine. In the Nordic group, we performed a study where we looked at lower risk MDS and ESA failures, transfusion dependent, treated them with AZA for 6 cycles. It was not very efficient, only 17% became transfusion independent. We gave them another 2 cycles of azacitidine plus EPO, and here only 1 patient responded. So our conclusion was that azacitidine alone has relatively modest activity in low-risk MDS, and the combination treatment is not really working. We also explored in the Nordic MDS group eltrombopag together with azacitidine. And here there were actually sort of two aims. We included high-risk patients with somewhat low platelets, below 75, and we wanted to see whether we could prevent the early platelet decline during treatment, which sometimes may lead to treatment delay and complications. And we also had a hope that we could get the hematopoietic stem cells to cycle and perhaps sensitize them to azacitidine. However, the response then, we saw 4 out of 12 patients had a marrow remission. There were 2 SAEs that were sort of thromboembolic, 1 TIA and 1 DVT. So the response was not remarkable compared to other trials, but we did see a stable platelet despite the treatment. And you can see here during the course of treatment that you don't see any clear initial drop during the initial cycles. So that was sort of a slightly positive result. Unfortunately, we saw no increased cycling of hematopoietic stem cells with careful flow cytometry analysis of the stem cell compartments. So in essence, we don't see any clear role for this combination treatment at this stage. Luspatercept then, finally, is a very interesting new compound, as you may be aware of. It's a modified activin receptor 2 beta coupled to IgG-Fc, and it traps TGF-beta superfamily members such as GDF11 and inhibits SMAD2 and 3 signaling, and it's considered to promote late-stage differentiation. And as you can see here, the earlier stages is EPO-dependent, and then here the luspatercept acts on the more maturing erythroblasts. And there's been a few abstracts. Uwe Platzbecker presented an update at ASH last year looking at 58 patients, transfusion-dependent EPO failures or with a high EPO level. And the treatment is relatively simple. It's just an injection subcutaneously every 3 weeks and very well tolerated. And in this setting, about 48% had an erythroid improvement. What was very striking was that the response, which was clearly better in MDS with ring sideroblasts, and especially in the subset with the splicing mutations. So finally, just to summarize then, ESAs are highly efficient for the majority, in fact, of the newly diagnosed patients with low-risk MDS, and it's recommended as first-line therapy according to major guidelines. Loss of response to check for deficiencies. Consider evaluating bone marrow evaluation if any clinical signs at all of progression. If not, then add to maximum combination dose, which may rescue the response. No evidence of increased risk of AML, and it may in fact improve survival. And in the future, I think eltrombopag and luspatercept in the near future is definitely highly promising, and combination treatments need to be explored further and may be of some value. Okay, thank you very much.